Hi, I'm Deepak Bhatt, reporting for ACC.org. I am here in sunny Barcelona at the European Society of Cardiology, and I am really lucky to have next to me my good friend, Professor Gabriel Steg from Paris. Really a true friend and a leader in the world of cardiovascular medicine. Welcome to ACC.org.
Hello.
So we're going to recap some of the trials from today. Really a lot of good stuff, but we've picked a few of them to discuss. Maybe we can start off with the Synthetix 2 study.
Yes, so Synthetix 2 is an analysis based on the Synthetix 1 randomized trial database, which you'll remember was a trial comparing CABG and PCI in patients with multivessel disease. Now, what the Dr. Escanet, who reported today, and his colleagues did is very interesting. They looked at patients with three-vessel disease and extracted a sample from the database and looked at patients who underwent comprehensive revascularization with physiological assessment of each lesions, high rate of use of FFR, IVUS, drug-eluting stent, comprehensive revascularization, CTOs, and a high rate of success of CTOs. And what they found is those patients with triple vessel disease who underwent these comprehensive assessment and revascularization had outcomes that were much better than the overall PCI group outcomes from the original Synthetix 1 trial. But interestingly, when they matched these patients with similar patients who were randomly assigned to the CABG group, then they found that the outcomes matched. And so that says that modern, quote unquote, PCI guided with IVUS and physiological assessment can achieve long-term results in triple vessel disease patients who match those of CABG. And I think this is really interesting given the evolution of PCI in recent years.
I agree with you. Lots of IVUS, lots of FFR, IFR, lots of second generation thin strut drug-eluting stents. So a good technique, good equipment, lots of CTO opening, high success rate. So in that milieu, PCI looked really good. Now it's not a randomized study, and you've got two interventional cardiologists, sort of preaching to the converted. Of course, we're going to say, yeah, PCI looks great compared with CABG. We're just looking for data to prove it, and this data provides it. But still, well done study, and I think it corroborates what we see in clinical practice. If you can achieve complete revascularization percutaneously, it really is pretty good and pretty durable, even compared with CABG. Well, and speaking of CABG, the next trial that we'll mention is VA DIVA. It's a trial I was involved with. VA-sponsored study looking at patients with vein graft intervention, randomizing them to drug-eluting stent versus bare metal stent, about 600 or so patients, mostly second-generation DS, versus bare metal stent in a blinded trial, no mandated angiographic follow-up. That had been some limitations of previous trials, lack of blinding, obviously not good. The mandated angiographic follow-up of prior trials tending to inflate rates. So VA DIVA was meant to overcome some of those, and the overall trial found no significant differences between bare metal stent or drug-eluting stent for vein graft lesions, not in the primary endpoint of target vessel failure at 12 months, not a longer-term endpoint at 3 years, not at components of the endpoint, such as stent thrombosis, though event rates were low. So overall, BMS looked pretty good in vein graft lesions.
It's a bit of a surprise, though, because if there's one subset of patients for whom we are wary of attempting these lesions, it's vein grafts. We know they're notoriously difficult acutely, and they give poor long-term results. And that would have been one subset where I would have expected that DES were really useful, and if I were to go into a vein graft, I'd really want to put in a DES. That being said, the data that we had so far was really not that strong to support DES, and I think this is going to be a really important addition to the evidence base.
Yeah, absolutely. There's no safety issue with DS, so no harm, no foul, but DS still costs more than bare metal stents, so maybe it's a requiem for the bare metal stent, who knows. But the other interesting part was the event rates were really high. At a year, target vessel failure approaching 20% in both arms. At 3 years, approaching 40 to 50%. So these patients that need intervention that have had prior bypass surgery are really high risk.
But it's also telling us probably something about the biology of vein graft failure, because it probably means that neointimal hyperplasia, which is targeted by the conventional drug-eluting stent, is not the major cause of the problem. So we probably need to refine our strategies for addressing this.
Great. And then the final trial we should probably cover is BIOFLOW. What do you think of that study?
Well, that's interesting. It's a study comparing the Orsiro stent, a thin strut stent, to the Xience stent, which the everolimus-eluting Xience stent, which gives good result and is widely used and considered as sort of one of the gold standards in modern interventional cardiology. And surprisingly enough, in this trial, which was not very large, there was a substantial benefit at 30 days in terms of clinical outcomes in favor of the Orsiro stent compared to the Xience stent, largely driven by an acute MI or in-hospital MI difference. So I think it's interesting, it's intriguing, it's somewhat unexpected. We have to put this, however, in the context of a number of observations. The first one is the sample size is relatively limited. Second, the randomization was imbalanced 2-to-1, so there was a relatively small proportion of patients in the Xience arm, and therefore the estimate of the event rate in the control arm is somewhat imprecise. And indeed, the observed event rate in that routine population, half PCI in stable CAD, half PCI in ACS, is a little on the higher end of what we would expect with Xience. They had, I think, a 7 to 9% event rate at 30 days, which would seem high by most standards. So I think it really is intriguing, but it would deserve confirmation.
Yeah, no, I think that's a beautiful synthesis of the trial. But even if it ends up just being non-inferior, to me that's not so bad, because if we could get a few more cheaper DS on the market in the US, that'd be terrific. In Europe, you don't have that issue. You've got lots of DS, the prices are better, but in the US, DS are still pretty expensive because we don't have as many choices. So even if it just gets one that's as good as Xience, that's still pretty good, I think.
Agreed.
Excellent. Well, thanks for that recap. Wonderful being here in Barcelona with you. Hopefully all you back home are having a nice time too.